Well, good morning, and welcome to Medical Alley, the global epicenter of health, innovation, and care. My name is Shay Mandel, and I have the honor every day to serve as the president and CEO of the Medical Alley Association. This is the next episode in our Bringing the Future Forward series, and today we're delivering straight talk on health inequities. I can't be more excited about the two panelists we have with us today. Dr. Christopher Warlick is the chair of the Department of Urology at the University of Minnesota and a leader of the mHealth Fairview Hope Commission to lead their health equity efforts. And we have Dr. Craig Samet, president and CEO of Blue Cross Blue Shield of Minnesota and a Medical Alley board member. For the hundreds of attendees, we will be taking your questions near the end of the program. Please use the Q&A feature in Zoom to submit your questions for Chris and Craig. And I'd like to get started this morning with just some introductions and a little overview from our panelists on what their organizations are doing, their leadership in this space. And Chris, I'd love to kick it off with you. Good morning and welcome.
Good morning, and thank you for the opportunity to be here. This is a great event. So, as you stated, I am at the University of Minnesota, and in conjunction with our partners at Fairview and also our M-Physicians, Academic Physicians Practice Group, we are launching a joint effort in an attempt to really help move all of our organizations collectively forward in terms of improving diversity, equity, inclusion, and health equity, both internally and then externally facing as well. And this is, as you alluded to, the Hope Commission, Healing Opportunity, People, and Equity. And this is a very large undertaking, as you can imagine, because all three of these organizations are quite large. And so working on ways to move things forward in a coordinated fashion to improve things both for, because we have many different roles, right? So as the medical school, we have learners that we are training. We want them to have a consistent experience when they're at the university, when they move to other Fairview sites. We want all of our community interactions at all the various Fairview sites with the different communities that we serve to be coordinated and a uniform experience as well. And so our providers also are functioning in multiple different environments throughout the system. So we are really trying to address several different aspects of equity, both again internally and externally, and trying to do this in a coordinated fashion. And so it is a big undertaking, but one that's extremely important. We recognize that as a group, we have different, there are several different roles that our organizations play, right? So our organizations certainly function as employers. And so again, making sure that we have an environment where all of our employees, whether they're physicians, nurses, the cleaning staff, everybody has an environment in which they feel welcome and can function at the top of their abilities. Obviously, we function as healthcare providers, and so making sure that we are providing care to all of our patients in different communities in an equitable, fair manner. As I mentioned, we have our roles as an academic institution where we're training the next generation of physicians and other healthcare providers. And then as corporate citizen, we know that our organizations do interact with the business community in a variety of ways, also interacting with the government in a variety of ways. And so we are looking to leverage some of those interactions to push forward health equity as well. So a lot of different facets to address.
Thank you, Chris. And again, welcome. Dr. Craig Salmon, if you haven't seen it for our audience or heard it, I guess, Craig has done one of our podcasts on leadership in a crisis. And I know he'll talk a little bit about that, as well as covering more Minnesota lives than any other organization. Craig, please, say a few words to kick this off.
Absolutely. Thanks, Shay. Thanks for having me. Good to see you, safe and well. I'm Craig Sammet. I'm the president and CEO of Blue Cross and Blue Shield of Minnesota. I've been in my role here for just over 2 years now. And as you mentioned, Blue Cross has been a staple in this community for a very long time, over 85 years. We were actually the very first Blue plan in the nation. It started here in Minnesota. And we're proud to serve nearly 3 million people who live in our wonderful state. Before the heartbreaking and intertwining crises that we find ourselves in today, I should start with the fact that diversity, equity, and inclusion, and racial and health inequities were very much an organizational top priority a year ago, 5 years ago, for some time. And I would share that our mission is very much to deliver high quality healthcare, good access, and exceptional service to the people we serve for every Minnesotan, not just to some Minnesotans, not just to many Minnesotans, but to every Minnesotan. So we believe in the notion of universal coverage, and we believe in the notion truly of equity. I would even go further to say that our strategy, which we have just enhanced and revised and presented to our board last year, was very much about the reinvention of healthcare. I've been at this a very long time. I'm a physician who believes that healthcare is broken. I'm a patient that believes that healthcare is broken, and I'm a health plan CEO that believes that healthcare is broken. I want to keep doing what I'm doing until this is fixed. And Blue Cross is very much committed to setting a new path beyond this crisis that really addresses the vulnerabilities and the weaknesses that we've very much seen. So we have been on a path to address racial and health inequities, but frankly, we haven't done a good job when we look back. And I would argue that many of us haven't done a good job looking back. Otherwise, we wouldn't have as big of a task that we have ahead of us. Our work is very broad-based, and I'm sure that we'll get into that. But we just on Friday presented to our board of directors a comprehensive plan for how we will not just speak up, but that we will stand up and that we will take bold action both inside our organization, in the communities that we're part of, and in this great state to deliver our hope that we provide high quality, accessible care to all Minnesotans.
Thank you. And I would also flag for our audience, one of the great things about the Medical Alley Association is having a diverse group of leaders. And I would certainly point to Craig as one of our key leaders that really are looking at the ability to transform healthcare. And I think that is something that here in this community, with the scope of leaders we really have an opportunity to do, not just for Minnesotans, but across the nation and perhaps even around the world. So let's jump into, kind of the scope and the scale of challenges. So you're both very familiar with the issues, Craig, mentioning years of targeting this, but outline for our audience, what are really the key drivers of health inequities? And is this a problem that our healthcare system can solve? And Craig, why don't we flip it back to you?
Well, I think that the drivers of health inequities are quite broad. I'd start first with racial injustice. I mean, I think that we have been open to stress the fact that we believe that racism is a public health crisis, and we have said that because we believe that racism has led to health disparities, which has led to health inequities, which has led to the poor health of this community. And I think in many respects, when we look at the effects that racism has had on our community, whether it's income disparities or housing disparities or access to healthy food alternatives, when we look at the social determinants of health as we describe them, many of them are driven off of racial inequities, and that's why the racial injustice crisis is so intertwined with the COVID crisis, which has disproportionately affected those same folks that face health inequities. So I think it's very broad-based. More broadly than just racism, I think that we look at housing and food and loneliness and transportation and income inequalities and inequalities and disparities that face the LGBTQ communities, gender inequalities. So many of these are drivers of health inequalities. And so to Chris's point, this is a big task because the challenges that we face are very foundational. And nonetheless, and I'll stop there, but I would stress that we do have a role to play. I think we all have a role to play, but even the healthcare industry, I think there's fears that healthcare getting into racial injustice or healthcare getting into the social determinants of health that will clinicalize the solution as opposed to really socializing the solution or really addressing the core issues. And frankly, I think it's an issue that we all own. I think we're all in it together, and we need to find a way to get outside of our lane to really address such a fundamental barrier to good health.
And Chris, I know you have a lot to say following up on a lot of Craig's comments. How big is this issue?
Yeah, I mean, I think Craig hit the nail on the head in the fact that, a lot of what we're seeing, I kind of think of this in a sense as sort of a pyramid, and the health inequities is really just that's really the tip of the pyramid. That's sort of the outcome of all of this. In a sense, the health inequities being the lagging indicator of things that are going on here. And so absolutely, so structural and systemic racism that lead to the things that Craig mentioned. So food insecurity, housing instability, mass incarceration, all of these things from a social standpoint contribute ultimately to what manifests as a health outcome. Even things such as for certainly African Americans, the chronic stress that comes from racism. Data showing increased cortisol levels and things of this nature that can lead to health issues in a very direct way. There are individuals advocating for making stress from racism an actual diagnosis, give it a code that allows for reimbursement for treatment of people suffering from this. And while that may seem like a controversial issue, it puts the fine point on the fact that this really does have health consequences. But all of these structural problems that lead to the social inequities, then at least in terms of health, the next level of the pyramid, as I see it, is sort of then all of these things lead to the middle section of the pyramid, which includes things such as lack of access to care. And that lack of access to care can stem from a distrust of the healthcare system, This may include, certainly for African Americans, a very long history of discrimination within the healthcare system. And of course, things such as the Tuskegee experiments that have left an indelible mark on sort of the collective memory of African Americans in this country. But also perhaps similarly, there may be a distrust of the healthcare system among undocumented individuals that are interacting with the health system for fear that immigration may become involved, and that may be a deterrent. In addition to another aspect of lack of access, of course, is affordability, in the fact that even when people theoretically have access, they may not be able to afford access to care or afford their medications. And so not having access to those things then can lead to things like delays in diagnosis and treatment, presenting with more advanced disease, and therefore outcomes may be worse. So again, the manifestations of the health inequities are really just the tip of the iceberg, and the foundational pieces really stem back to a large extent on some of the systemic and structural barriers that have been prevalent in our country, obviously currently, but historically. And is this a problem that the healthcare system can solve? Well, I mean, obviously we have to believe that's true, but I will say that the healthcare system, at least the things that the healthcare system can directly impact, to my mind, it really is sort of the middle and the tip of the pyramid. So things that are dealing directly with the delivery of care. However, and I think that those are the traditional approaches that we have taken, sort of trying to address things that we feel we can directly impact. But I would argue that in terms of how to do things different, that there may be an incentive to try to throw the weight around of some of the healthcare institutions to address some of these more fundamental social determinants of health, but again, in a more structural fashion, getting at some of the root causes that result in poor social determinants of health. Because ultimately, it's really going to require affecting those fundamental things in our country that lead to all these downstream effects. Because otherwise, we're just sort of treating the symptom without really addressing the cause. And perhaps we haven't organized in a way as a medical community to address those perhaps as well as hopefully we can in the future.
So Shay, this wouldn't be nearly as fun unless you had disagreement amongst your panelists. So I hope I can
jump in.
Go first and really again double down on the fact that I do believe the healthcare industry has a responsibility. I'd like to point out, and going back to my practicing days, that my responsibility as a physician is much about health as it is about care. And I may be unique in that I grew up in an environment of integrated delivery systems that were very much focused on population health. And I would view it as a personal failure if one of my patients got sick for drivers that were upstream before they even got to me. And, I've been part of organizations that have bought air conditioners for patients because they were admitted with COPD exacerbation because they didn't have fresh air in their homes, or there are health systems in our state that have created food pharmacies, spelled FARM pharmacy, to avoid patients from coming to emergency rooms because they're hungry. So I think if we look at healthcare through a lens of one of the ways that I think we need to change, we have to be about wellness and prevention and population health, not just about treatment, which we already do very well through Fairview and others. But I do think that one of the ways our industry needs to change is that we do have to take a bigger step toward accountability for this. The other thing that I would add is that I think one of the challenges clinically is we haven't thought of healthcare through an equity lens. We've thought of healthcare through an equality lens. And so I think traditionally in healthcare, we say, well, for every patient who comes in with diabetes, we'll treat them exactly the same. That's equality. Equity is when we say we want to assure that everyone with diabetes has an equal opportunity for cure, or that the outcomes are comparable, not the process. So I think one of the other things we own as a healthcare industry is not making it equal, but making it equitable, which is much more about outcomes. And that is very much within the bailiwick and the control of the healthcare industry.
Yeah. And to be clear, I think that it's not a question of whether certainly I don't think we disagree that there is a responsibility of the healthcare industry. It's to my mind, it's just a question of, to some extent, of where we're putting the efforts and how we're applying the pressure. Because again, it's great to, and in fact, I would argue that there is that there will be a rationale and more of an incentive, in fact, going forward for putting pressure, again, whether it's on government or policies that affect things much further upstream, because as more and more of the burden shifts for cost onto the healthcare industry, we're going to be more and more incentivized to not just buy air conditioners. That's great. That solves the immediate problem. But how about addressing the housing issues that sort of result in people living in areas that again, where their health becomes at risk simply because of where they live? Because stopping those problems up front, or helping provide solutions up front so that people don't end up having exacerbations of their asthma, may be a more cost positive approach down, sort of down the road. So, and again, Craig, certainly from where you sit, you have a much bigger view of this whole issue in terms of how costs fall into it. I won't pretend to be an expert in that at all, but I do think that, again, we should be thinking bigger and more broadly about other pressure points or ways to apply pressure a little bit more upstream from the things that we do on a day-to-day basis.
Agreed.
So I wish we'd have booked 3 hours, because I've got a list of 10 follow-ups. I'll try to navigate this in a way that works well. So both of you mentioned seeing things through a different lens. Craig, you mentioned equity versus equality. Part of the question is, what can healthcare be doing? And both on the cost and outcome side, you've both talked regularly about prevention and wellness, right? Big terms that people throw around. Do we need to be redefining prevention and wellness through this lens that you're both articulating, that is really about equity? And I'll say the last piece, Chris mentioned, those who can throw their weight around, and I'll affirm that both of you can. So do we need to be redefining prevention through a different lens?
And I don't think we need to redefine it. I think we need to do it. We've long used the expression that an ounce of prevention is worth a pound of cure, but the reality is that's not how we prioritize the healthcare industry. We do in other industries. There are a lot of things that we do to keep us out of trouble in just about every other part of our lives, but in healthcare, I had too much time on my hands at one point, and I did the math, and I said, okay, well, there are 16 ounces in a pound. So the implication is that if we spend $10 million in preventing illness, we'd save $160 million of badness, of things that shouldn't happen, of keeping people from getting sick, or keeping people from getting cancer, or keeping people from being homeless. And so I would put all of this in the definition of wellness and prevention. It's the traditional stuff, which frankly, we haven't done well either. So just in terms of health and wellness prevention protocols, fitness, weight loss, nutrition. But add to that social determinants of health, racial inequities, mental health, they very well may all fall into the ounce, so to speak. And I don't know if it needs a redefinition and sort of it just let's do it for once. We've used the expression, now let's take this opportunity to advance it.
And Chris, how do we
Yeah,
do?
and I guess I would say, you know, when we talk about you know, prevention and wellness, I you know, especially the term wellness, I think may mean different things in a sense for different groups of people, because certainly I think that oftentimes when people refer to wellness, at least in common parlance, you're seeing you know, encouraging people to take extra time for their, you know, to take time to meditate, for instance, and focus on your mental well-being, et cetera. And that's a luxury that unless you have your basic needs met, you will not have the luxury of being able to engage in wellness in that sort of, in that sense of the term. And so I think that in a sense of do we need to redefine what that means? I think that for some populations, wellness may in fact have a very different definition, and wellness may simply be being able to meet basic needs, being able to have access to food and having access to shelter may be the first steps in their wellness program, if you will. And then for other people that are not perhaps that socioeconomically disadvantaged, then yes, then maybe it becomes a question of, again, having access to medications, going back to the question of sort of access to care and affordability. Because again, that's where we've sort of begun to traditionally think about prevention. Like, are you taking your high blood pressure medication so that you don't end up having a stroke, et cetera? But really for some of our communities and for some of our members of our communities, really prevention starts even earlier in terms of, again, having basic needs met before we worry about, you know, whether they're getting enough exercise. So in that sense, yes, we probably do need to redefine it in a sense, and it means different things for different to different people, I think.
So Craig, you mentioned everybody being willing to get out of their lane. So, you know, you're both talking about a set of drivers that traditionally we would view as being outside of healthcare. And I like the, you know, clinicalizing these bigger, broader social issues. But there are vast implications. Is there an opportunity for healthcare leadership, which I think is highly respected, in particular here in Minnesota, to really be weighing in with elected officials on these broader issues in a way that we haven't before?
You know, I've long held the belief that reinvention of healthcare is a team sport, and I think there are many people who play a role in this in the state that are well regarded and well respected. But I think the reality is we can't work in our silos. We have to work in lockstep. So I think that's been part of the problem, that we've sort of all owned a little piece of it. And because we've all owned a little piece of it, the solutions have truly been fragmented. So what role does the care delivery play? Does health insurance play? Do social service agencies play? Do regulators and legislators play? And maybe I'm Pollyannish about this, but I think that there is a solution where the whole is far better than the sum of the parts in solving this problem. And I've wondered, sort of, can we even pilot this? You know, the one way to think of it, and I've discussed this with several of my peers in various forums, is, can we all work together? Let's pick a problem. You know, there are lots of problems in healthcare, many of them related to racial and health inequities. Let's pick one. Let's pick one and let's work together to demonstrate that collectively we solve it. Health insurance and care delivery touches every Minnesotan in one way or another. Can we solve for food insecurity? Can we play a role in partnership with others to solve for food insecurity if that is one of the key drivers? So I do think there's an opportunity to raise our voice, but I think we have to raise our voice in conjunction with a lot of other people who would raise it with us.
Yeah, I think my comment on this would be that sort of as we indicated before, I agree that to Craig's point that maybe some of the efforts previously that groups have engaged in addressing certainly the legislature and the government entities have been sort of in addressing policies that may have direct effects on their specific interests or bottom lines. And in addition to those sorts of efforts, again, I would advocate that that it's important to maybe engage on these topics like food insecurity, housing, things that again traditionally have fallen just outside of the purview of health systems. But again, I think there's a growing incentive to do so. As again, if you look, so think about this from sort of the healthcare delivery standpoint. So if you look at models where again a healthcare organization will be responsible for the health of a population, and they're going to be responsible for all aspects of the care and health of those patients, then certainly, in addition to making sure that the immediate medical needs of those patients are met, it would also behoove you to support public policy that may, again, provide stable housing for the population that you're dealing with, to make sure that there are no food deserts among the area of the populations that you are dealing with, because we know for a fact that those things will contribute to worse health outcomes and therefore higher costs for you as the healthcare organization. And so, so I think that as some of the models of care change, there is going to be an increasing incentive to work upstream, and again, some of those partnering with government in a way to address again these, going back to these, just it really is the base of the pyramid concept, right? That these very basic issues. But I think in the past that we have been lobbying to address issues that we thought were pertinent to our individual organizations. And again, if we are a company that makes medical devices, pushing against taxing medical device development, right? The pharmaceutical company is going to lobby against things that hamper their ability to conduct the business the way they need to, the way they see it. And insurance companies similarly are going to lobby against things that they see as disadvantaging them. But I think that the time, may be ripe now to, again, not only advocate for those things, because I understand the logic behind why these entities are doing this, but also then to more broadly engage in public policy. And again, hopefully perhaps in a coordinated fashion that will ultimately provide solutions to some very basic problems in our society, that not only will they have improved implications for health, but will also likely have improvements in the economy, which is beneficial for everybody, and also may then also decrease the pressure on some of the other social welfare programs that are out there, and again be beneficial for all of us, in terms of maybe even tax dollars and everything like that we're currently spending. So so I just think we need to look a little further. Again, I keep saying the same thing, but looking more upstream at addressing some of the very basic and systemic issues that affect us.
Well, it's never a good panel if we don't bring up lawyers or lobbyists. So I appreciate that both of you have. There have been efforts, things have been tried. Craig, you're suggesting we just do it. And as you both know, state of Minnesota ranks very highly, typically top 5 in the United States in terms of overall health. But we rank kind of middle of the pack in terms of disparity of health outcomes for people of color and challenged populations. So we definitely got an opportunity, but some work to do here. What have been some of the issues from your perspectives in terms of moving the needle? Why haven't some of the smaller efforts, individual efforts, or projects that have been done in the past? Is it a failure to sustain, pick the right projects? Why aren't we making more progress?
Chris, do you want to go first?
Sure, I'll take a stab at this. I mean, I think that there are going to be several different reasons, right? But not the least of which is, again, if you are treating just addressing the very tip of the iceberg, and you're not addressing the fundamental causes, there's only so far that you're going to be able to get. And so I think that's one fundamental issue. In terms of, there have been some successes. There have been pockets of progress that have been made, and so it's not a completely bleak picture. But one of the things one of the concepts that I like, that I have come around to, that a friend of mine, Alfred Bevington Johnson, is constantly saying is, when you're looking at developing projects in a community, you want to try to make sure that the projects are not only addressing whatever the immediate need is, but that you're building capacity within the community that you serve. And so what does this project, in addition to addressing the immediate need, will it leave the community in a better place than it was before you came? Will it lead to the community being able to be more self-sufficient, self-sustained, so that hopefully in the future you won't even need the program that you're putting in place? And so I think that that a lot of the efforts that have occurred in the past have been addressing a very immediate and necessary problem that needs solving, but perhaps there hasn't always been as much effort paid to the sustainability, and again, even more important than just can we stay active in this project in the community for a long period of time, maybe asking the next level question: are we providing resources for the community to build itself, so that the community becomes self-sustaining, and then again, maybe we obviate our even need to be here. And so I think that that's a great concept and a challenge for everybody when they're thinking about community engagement projects to address these issues. Again, is your involvement going to result in leaving things sort of better than it was when you came, and in a sustainable manner?
So I focus on my remarks in 3 areas, and I had to write down the words so I don't remember them because I'm old. It's bravery, it's policy, and it's payment. So bravery is, I sort of feel like we've had the opportunity to make this pivot, but it's either been uncomfortable or difficult or challenging, or that this is the way it's always worked in our industry. And so why change something if we don't think it's broken or before we're forced? And so I think a lot of it is going to require bravery of leadership to step in a different direction. And I don't know if we've had that. And I think that's one of the things that may be different this time. And hopefully we'll see many more people that are bolder. From a policy perspective, I'm sure that everyone is learning. We're all learning, especially as it relates to social injustice. But I think we have to start changing policy as opposed to just trying to change people's minds. And I think once we take those brave souls and we start to enact things that really do address prevention and inequities and social determinants of health, that's when we will begin to change people's minds, and that we'll actually begin to see an evolution in the right direction. And then payment is, you get what you reward. And I don't know if we've been rewarded truly for population health. I don't know if we've been rewarded to really go upstream, as Chris describes it, or that we address the root causes. Our industry is rewarded for everything that happens downstream. And so I think only when we really change payment will we address the inequities. The one example that I'd also give for those in your audience may have seen it, there was a great article published by the Washington Monthly, and the description was, or the title is, Introducing the Best Hospitals for America. And the premise is, what if institutions are recognized for the fact that they save lives, they save money, or they serve social justice? And they actually did a ranking of hospitals in the US based upon those measured priorities. Sadly, not a single hospital in Minnesota was on the list. That we define best hospitals in a different way, but it's not about saving lives or saving money or social injustice. What if the reward and recognition was truly about the health that we seek? I think that's why we haven't made change, and I think that's where we have to probably go in the future.
And I would go, I would add another comment, and again, maybe this is back to Craig's point about leadership, because you know, one of the things that has become clearer to me, certainly recently, but you know, it's sort of been recognized for a long time, but has been examples have been made more clear recently, and that is that, you know, when it comes to sort of social change, social change tends to happen when the people that are in power decide it needs to happen, right? So again, if you ask people of color, we've been complaining about all sorts of inequities and problems in this country for, well, since we got here, quite frankly, right? And yet, here we are still talking about it, you know, years and years and years later. As you pointed out, lots of individual attempts, but things have not succeeded. I mean, in a global sense, you know, obviously things are better now, perhaps in many ways than they have been in the past, but in many ways, a lot of the same things are going on, just in different forms. But when the people that are in charge, people that are in the hold the seats of power in our institutions, decide that something needs to change, it needs to change. And so, you know, and again, one very recent example, again, that I think makes the point is the changing of the Washington Redskins football team, named to now the Washington football team until they get a new name. But, you know, Native Americans have been clamoring for a name change for many years, decades, in fact. In fact, when I was interviewing for medical school, the Super Bowl was, and I went to medical school here at the University of Minnesota, and the weekend of my interview happened to be the Super Bowl in 1992, to date myself. And the Buffalo Bills, and I'm from Buffalo, New York, and my father played for the Bills when in the 60s. So I'm a diehard Bills fan, and I ended up going to that game when they were playing against the Washington Redskins. There were protests outside the stadium against the name, you know, going back to 1992, and again, the protests even predate that. But nothing happened for decades until the corporate sponsors decided that enough is enough. We think it's important now. We want to make a change. And within a week and a half, it was amazing, the turnaround. But in about a week and a half to 2 weeks, it went from, you know, this is something that we can't do, to being done. And why? Because people decided that people in power decided it was important to do, not because the Native American community was able to make the change, but they were able to convince the people in power to make the change, and then boom, it happened. So, so I think that when we decide that this is important, and when the people in power decide that this is important, then things will change. You know, the other example that is again relevant to right now is just the tremendous sort of coming together and the tremendous amounts of collaboration that we have seen in response to the COVID pandemic. And so we have, as certainly as a medical community, come together, whether it was to make sure that we had adequate PPE, whether it was to come up with expanding the testing in our state. We've changed the way that we see patients with an explosion of telemedicine, again, something that had been talked about and thought about for many, many years. And then in the span of about a month, we went from like doing less than 1% or about 1% of our visits to televisit to 80%. I mean, it's amazing what can happen when we decide it's important to do it and it's adequately resourced. And so our response to the pandemic has shown what we're capable of doing when we decide it's the thing that needs to happen. So if we were to put similar efforts into improving health equity, I have lots of confidence that we could make some significant milestones relatively quickly once we focus.
We do have tons of questions from our audience, and I'll get to them, but I do just want to do a follow-up on that. So Chris, you have said repeatedly solving these issues is going to require creativity. And Craig, I know you've had a tremendous vision for how we transform healthcare, talking about innovation, different collaborators. COVID-19 has opened the door. So let's forget about where we've been. For both of your organizations, I mean, do we need non-traditional collaborators? Is technology, changes in care delivery and access critical? Paint us a little picture of the kind of innovation, creativity, and collaborations you see as necessary to really accelerate change around these issues.
Greg, this one's yours.
You know, so what got me into the mess that I'm in and reinventing healthcare really stems back to my business education. Because I spent 2 years hearing case studies about the best companies in the world. And not one of those case studies was about a healthcare company. And it was because the types of inventiveness and innovation and creativity that you're asking about are what has really transformed and made successful key companies or key industries for that matter. So I think all of what you say applies. The reality is that if we could start with a blank page, and if our goal is people live a very long life, everyone lives a very long life, and healthcare is affordable, and healthcare becomes a service industry that finally acts like one, and is convenient and not bureaucratic, we would not create what we have today. I think we'd come up with something different. So what is the Tesla of healthcare, or Uber of healthcare, or Netflix of healthcare, where we step away from what is traditional and think very differently about what we would create? And I would say now is the opportunity, especially as we see the weaknesses in our system with COVID and racial injustice. Now is the time for us all to get a whole lot more inventive.
Yeah, I mean, I would echo that. I think that, many people have asked, so everyone, lots of people, not everyone, but lots of people have a sense that now may be different, right? So again, things that were this public outcry after George Floyd's murder that has sparked a lot of recognition of again of a chronic problem in this country. But there's a sense that despite the fact that we've been through crises before and lots of killings of Black people in this country before, that now may be different, and it's broadened the discussion again beyond just sort of interactions of people of color and the police to, again, having a discussion on health equity, right? It's broadened the discussion, and there's a lot of sense that things are different now. And part of the reason that I think that it may be a little bit different now, really, I do bring back to COVID. I think that we have, that due to the massive changes in our lives and how we are doing things on a day-to-day basis that have been necessary due to COVID have sort of opened us up to new possibilities. So all the things that we thought we couldn't do before, all of a sudden we've found ways to do out of necessity. But it has, I think, opened up our mind sort of collectively to new possibilities, to being more open to change and establishing I hate to use the hackneyed term new normal, but essentially, let's just call it to open ourselves up to something new. I won't call it necessarily normal, but something new in a way perhaps that we haven't been open to so much in the past. And also the fact that it is a collective effort to establish new ways of doing things, not because this has hit kind of across the entire economy, across the all levels of society, obviously some more than others, no question about that, but everybody has felt some effect from this. All businesses have felt some effect from this. And so from that perspective, I think there's a lot of groups that are, and people that are now all open to change at kind of the same time. And I think that it's that possibility of coordinated effort that again may be different. And so that leaves us open for innovation. But again, I think innovation has to be fostered by support, and because lots of good ideas, won't get off the ground if they're not adequately supported and resourced. So there is an opportunity for innovation. I'm not going to pretend that I know know the answers of what should be done exactly, but there's a lot of smart people out there thinking about it, and so we just need to make sure that we take advantage of this moment, make sure things are adequately resourced, because again, we see what can happen when we put our mind to it in terms of our reaction to COVID. So let's apply it to this.
So we all know there's misalignment of incentives. It's always one of the things that we fall back on in terms of not defending, but explaining the current system. Craig, you touched on something I think really interesting in talking about the rankings of hospitals that included racial justice as being a component. And Chris, I know you've been an advocate for how all organizations step back and really prioritize the lens of racial justice as they look at their entire business. So I'll ask both of you, can you see a world in the shorter term where racial justice measurements tied to population health should be part of a value-based healthcare definition that have aligned incentives? And is that something that your organizations can really help drive?
Yeah, I'll jump first, and I'd start by hopping off of Chris's comment that those that are in positions of power can influence change. I would argue that we're all, in many respects, in a position of power in some way or another. That solving for racial injustice begins right here at home, and whether it's assuring that our teammates and our leadership reflects the community that we serve, or whether it's really looking at policies that are unjust, or whether it's really focusing on equity of health benefits or other benefits for our people, that we all have a role to play, and there isn't just a single person in power, or there isn't just a state that's in power. I think we have the opportunity to lead by example. And I think I very much, to directly answer your question, I do think that we're going to see dashboards and scorecards that will reflect a different way of measurement and a different reward system. I mentioned that we've put together a comprehensive plan. At the very top of that comprehensive plan is a list of measurable objectives that we want our board to hold us accountable to, and that our leadership's incentives will be tied to, that include this priority area of focus. And it's not just inside our organization, it's also achievement of racial and health equity out in the communities that we serve. And so I think if we, going back to my 3 words, if we're brave and we go in this direction and we do change policy, which we will, and we start to assign payment to it, either to ourselves or even the way that we reward our partners, our vendors, the people that we work with, the people that we use, I think that's how we're going to really drive change. So I would very much predict that we're going to see a whole lot more of that going forward.
Yeah, I would agree that I think that there's a high likelihood, and certainly, again, within the organizations that I function, there absolutely is more attention being paid to this, and outcome measures and metrics that are going to be assigned to these ideas. In an expanded way, again, looking at not just sort of, what are the numbers of people, for instance, of underrepresented minorities that we have in the organizations, but again, looking out into hopefully, examining things such as, our interactions with vendors and things of that nature. One important concept that one of my colleagues, Taj Mustafa, who's also one of the leaders of the Hope Commission, is constantly reminding us of, is the concept of sort of representational diversity. So when we're measuring ourselves, if you will, in terms of how we're doing with diversity, it's not simply enough to say, well, if there's 10% of the population are Asian, then we should have 10% of our workforce as being Asian. It's much more to the point of, do we have enough diversity within our organizations to match the engagement of the communities that they represent? So that when somebody from one of these communities comes to interact with our health system, is there always going to be somebody there that perhaps represents them, to have a sort of to reap the benefits of having that diversity. And so oftentimes that results in an over-representation from a percentage standpoint to achieve the functional representation required in the interactions with the patients. And so it's going to be important as we, if we have metrics that we're going to be measuring ourselves by, it's just important to remember that a lot of thought will need to go into how you design those metrics to make sure that they actually are achieving what the goal is, and not just achieving satisfying sort of a number metric. So I do think that there will be, we are moving in that direction, but I will just say that we'll certainly need to be very thoughtful about how we do that to make it worthwhile doing.
Well, as I watch the clock, and for our audience, I have attempted to weave in many of your questions. I will share with Chris and Craig. There are a lot more. People want to talk about mental health as a catalyst for a lot of these issues. And so I think we'll definitely just have you two back to have this conversation on a regular basis. But want to give each of you the opportunity, and Chris, we can start with you, and Craig, give you the last word. Just a final takeaway for our audience to help people, begin to shift and Any comments on leadership of our industry taking this forward? Chris, last comments.
First off, I just want to say thank you to both Shay and Craig for the opportunity to have this conversation this morning, to Medical Alley for allowing me to participate. This has been wonderful. And as you said, hopefully sort of perhaps the first of many conversations. And that's actually part of my take-home point here. And that is that one of the ways forward, sort of in a broad sense, is to begin to normalize conversations regarding equity, social injustice, racial injustice, gender discrimination, et cetera. Normalize these conversations instead of making them sort of a special event, if you will. So integrating these thoughts, these discussions into our everyday action, sort of how we're doing business. And I think that is going to be an important part of moving all of this stuff forward. Is just beginning to talk about this regularly, be thinking about it regularly. One of the million-dollar questions that back to the question of incentivizing people to do the right thing, and that is, figuring out how we are going to convince people that otherwise don't have an obvious reason for wanting to engage in this work and to be thinking about things to do so. Because I think that it's going to require a collective effort, and as many people as we can pushing in the same direction will be important to push things forward as quickly and as far as we can. And so I think thinking about how we're going to convince people beyond simply saying it's the right thing to do, how we're going to incentivize people to engage in this work. But I remain very optimistic that we can make improvements here. This is a unique time in history, and I hope we don't squander the opportunity.
I'll start where Chris finished. I think we have an opportunity and an obligation to really make real change in our industry now. And frankly, I would say, if not us, then who? If not Minnesota, that has always been an innovative leader and has been at the forefront of transformation. If not us, who? One of the things that keeps me up at night is I worry that we'll get through the today of these crises and we'll go back to yesterday. That we will long for the way things were, which is a broken healthcare industry. I think we need to go to the day after tomorrow. Let's leapfrog the next incremental step. Let's take the opportunity to be transformational. Let's not miss that opportunity. Let's not squander it, as Chris puts it. Let's take the mantle and run with it. So that would be my invitation and my charge to all of us.
Well, Chris and Craig, thank you so much. Truly a pleasure. And it's exciting to have leadership in this community. As Craig said, let's focus on the day after tomorrow. For those of you watching, this is our Bringing the Future Forward series, and we'll continue to bring leaders like Craig to the table to talk about ways in which we can be and need to be transforming healthcare. And again, a big thanks to Chris and Craig. For our audience, please, you can go to medicalalley.org. You can find Craig's podcast and many others, as well as our catalog of webinars we've done and those we have coming in the future. And I'll invite everyone to please continue to join us for the conversations that are really driving the future of healthcare. Everybody, have a great Medical Alley day. Thank you.